Good evening, everyone. My name is Mehra Golshan, and I'm a breast cancer surgeon here at Yale. I'm the clinical director of the breast program and really excited to be here this evening for the Smilow Shares Breast Cancer Awareness Month. We have three preeminent authorities in breast cancer this evening, Dr. Anca Bulgaru. We're going to have Dr. Legare and Dr. Meena Moran talk about advances in oncology, radiation therapy, and really just the state of the art in treatment in breast cancer. We're going to have three separate presentations, and then at the end there'll be a question and answer period where, and even in advance of the end, if you want, please put in any questions into the chat box or the Q&A box that's at the bottom of your screen. We've held two of these forums for Yale, for the New Haven, and also for the Fairfield Bridgeport. It's been really well received, and this is going to be the highlight of the month for breast cancer awareness and Smilow Shares. So with no further ado, we're going to start with Dr. Legare, who's going to talk about some advances in breast medical oncology. Then Dr. Meena Moran in radiation, and certainly not last and not least, but we'll have Dr. Bulgaru talk a little bit more about some of the advances in oncology, and then look forward to some really great questions from the audience. Thank you. Dr. Legare, the floor is yours.
Thank you, Mehra. Appreciate that. And I'm very happy to be with everyone tonight. And I'm going to try to share my screen. Just let me know if you can see things properly. Can you see my screen? Okay. So good evening, and very excited to share some thoughts with you, regarding breast cancer, maybe where we're heading, where we hope to head, and some of the advances that we've seen come forward this year. We know that breast cancer remains significant. It's the most common malignancy that's not a non-melanoma. Skin cancer in women, estimated to be about 276,000 new cases this year. So we know that this is a very significant issue for our women across the world, and certainly in the United States, and something where research really, I think, is moving forward in a very hopeful way. You can see on that top sort of purple-pink part of this graph that, breast cancer probably had a little bit of a dip in the early 2000s in terms of incidence rates. And that was perhaps based on folks moving a little bit away from hormone replacement therapy. And then after that, we can see maybe a small rise, maybe a 0.3% per year increase in risk of breast cancer that we've seen subsequent to that, perhaps over the last decade. And I would say, as a combination of early detection with mammogram, having shown to decrease mortality from breast cancer through screening, and also with advances in treatment, we've seen, thankfully, especially over the last decade, significant decrease in breast cancer mortality. So we've seen perhaps a 40% decrease in breast cancer mortality since 1989, after seeing essentially fairly flat lines before that. And you can see that again in that purple-pink curve there on the graph. So we are making progress. We can never be complacent. We have a long way to go, but there's room for hope. When we look at 5-year survival rates, this can also be reflected, going from the 70s to the 80s to the last decade, and we're seeing 5-year survival rates increase from 75 to 84 to 91%. I was going to focus a bit on ER-positive, HER2 negative breast cancer, and later tonight you'll hear some advances in HER2 positive breast cancer from Dr. Bulgaru. We know that early breast cancer accounts for perhaps 90% of breast cancers diagnosed in women, and that 70% of those are hormone receptor positive and HER2 negative. We know that thankfully most women won't experience a recurrence, but some women will be at higher risk, and those will be folks who have had high-risk features, and they can experience recurrence sometimes within the first few years. And one of the questions we ask is, why is this happening on our current therapeutics? And one question that we look at is the question of endocrine refractoriness. When one is getting treated, say, with endocrine therapy of some type, what's permissive for that cell, if it exists within the body, to then grow back and manifest as stage 4 cancer after one is presented with early stage cancer. And there were some interesting trials that were looking at this question a bit at our American Society of Clinical Oncology meetings earlier this year. So I was hoping to highlight just a few of those trials, and then to just take a look at some of the clinical research that's happening at Yale right now to share with you. This is a cartoon of sort of cell cycle kinetics, if you will, and how a protein called cyclin D works and how it affects cell cycle kinetics. And just looking at that green circle RB, RB, which is the retinoblastoma gene, is very important in controlling whether a cell replicates, makes a copy of itself, cell growth, cell replication. We know that dysregulated cell growth and replication is the hallmark of cancer. And we know that mutations within cancer cells are what ultimately causes that. There's data in the stage 4 setting that adding a cyclin-dependent kinase inhibitor to endocrine therapy, hormone therapy like anastrozole or an aromatase inhibitor, or a SERD like fulvestrant, can almost double the progression-free survival in the stage 4 setting. And like many aspects of how we study cancer, if something looks very hopeful in the stage 4 setting, we try to move it back to the early breast cancer setting and say, hey, can we do better? So documenting benefit in the advanced setting and trying to block that a movement from the G1 phase of the cell cycle to the DNA replication phase. We've tried to look at these agents in the early stage of breast cancer. So this was a trial called Monarch that looked at women who had early stage breast cancer that had some high risk features, such as 4 or more involved lymph nodes, or 1 to 3 involved lymph nodes with other high risk features like grade or size of the tumor, large tumors. And it was a big trial with over 5,000 women, and essentially randomized those women to endocrine therapy. On the left, you can see ET with a particular cyclin-dependent kinase inhibitor called abemaciclib, or endocrine therapy alone. So half the group got endocrine therapy, half the group got endocrine therapy with this cyclin-dependent kinase inhibitor. And this was a phase 3 randomized trial. And what you can see where I put those numbers of 88.7 and 92.2% is we're seeing, with a median follow-up of about 15.5 months, that the curves there are starting to separate. And we're seeing that the folks who received the cyclin-dependent kinase inhibitor, some of them seem to be doing better. The absolute benefit was perhaps 3.3 or 3.4%, but it's early in this trial. And this is a signal to us that we might be seeing an important benefit for some women by adding this agent in. So I think that right now this could be an option for some women with very high risk features. I'd like to see confirmatory trials saying that this and other cyclin-dependent kinase inhibitors, there are 3 that are FDA approved, but the other 2 show similar benefit. But I was really happy to see this presented. And this was at actually a different meeting called an ESMO meeting in earlier this year, which is a sort of a parallel to our American meeting. So I want to focus just a minute on another targeted therapy that's had FDA approval for a few years in the setting of stage 4, again, ER positive, HER2 negative breast cancer. And this is an agent called alpelisib. And what you can see here is that this agent specifically blocks the alpha isoform of a protein there you can see in pink called PI3 kinase. And if you look at this cartoon on in the outside world where that orange circle says growth factor, these are the proteins that are stimulating cells to grow, to divide, to make more of themselves. And can we get at that particular cells, cell mechanics? Can we get at that and block it to try to prevent these cells from either moving through endocrine therapy, or can we make endocrine therapy, work better? And so that's kind of what we're looking at here. And what we've seen is that in the stage 4 setting, for a particular subtype of women, these agents can be very effective. And that was a trial called SOLAR-1. And in that trial, again, almost a doubling of disease-free survival for women, with this agent. And what we've seen is that, about 40% of women with ER-positive, HER2-negative advanced breast cancer harbor this mutation. So alpelisib really is, in a way, a targeted therapy, getting at a regulation problem where the cells are sort of hyperstimulated. They have a mutation in this gene, and this mutation is permissive for cell growth and cell division. And so adding it, and it's not an uncommon mutation. It's in 40% of folks with ER-positive, HER2-negative breast cancer. So Hope Rugo at UCSF had said, well, can we look specifically at this subgroup that has, this mutation and already has seen that cyclin-dependent kinase inhibitor that we talked about a while ago? Because as our newer therapies come into play, we're trying to understand the influence of a prior treatment on a subsequent treatment. So the question that Dr. Rugo was asking was, well, since cyclin-dependent kinase inhibitors that we looked at earlier, since that's standard of care for women with advanced ER-positive, HER2-negative breast cancer, what about women who have been exposed to that? Will they still respond to this new agent, alpelisib, in the context of this PI3 kinase mutation if they have been exposed to the cyclin-dependent kinase inhibitor? And I was very happy to see that the graphs here looked very similar between the original SOLAR-1 trial that was published a few years ago and this trial called BYLieve, where if you can look at the graph with the sort of vertical lines going down, that would suggest a response in terms of decrease in size of tumor. And the graphs almost mimic each other. So they're sort of saying that, well, we do believe that this agent is going to be effective in women who have had a cyclin-dependent kinase inhibitor. And so, someone coming through with standard therapy, ER-positive disease, stage 4 disease, getting endocrine therapy and a cyclin-dependent kinase inhibitor, if they have this PI3 kinase mutation, this is a very viable option for them to go forward. And again, a doubling of the disease-free survival rate. So, moving forward, trying to get beyond endocrine refractory disease. So to me, that was very hopeful. So I wanted to transition for a minute and just spend a few minutes looking at some clinical trials we have up and running at Yale, and some of the focus that we're looking at. And part of what we understand with cancer is lifestyle exposures. And one of the questions that we're trying to look at is exemplified in this Be Well trial. The PI here is Dr. Sant, and this is a trial looking at saying, is weight loss after being diagnosed with breast cancer, can that affect outcomes? So this is a very large trial across the country, and women are being randomized to either, no intervention or an intervention with counseling about diet and weight loss, and seeing if that translates into an outcome of benefit for these women. So this is an important study. We know that women coming in with breast cancer, if they're considered, clinically overweight, sometimes their outcome, there's some data supporting the fact that their outcome might not be as good as women who are a bit leaner. So we're trying to understand that better. This is a trial called the ABC trial, and looking at aspirin in early stage breast cancer. And the question being asked here, and Dr. Fishback is the PI of this trial, we really have a deep resource of multiple oncologists who are focusing on breast cancer at Yale. And I think that it really delivers innovation and quality care to our patients. Aspirin and other agents like aspirin have been looked at in multiple malignancies for potentially, preventing or decreasing risk. And this is a trial asking the question, well, there's a lot of basis to consider this question as a very relevant question. Could the addition of aspirin affect outcome? Would women potentially do better? So this is a very relevant trial for us as well. I just list a few other trials. A lot of these happen to be national trials, but just to look at the top three, one looking at different molecular changes in a woman's breast tumor and then randomized to different therapy before surgery based on what those, what the molecular profile, the molecular landscape might look at. Again, Dr. Sant is the PI for that trial. Another trial, perhaps like that Monarch trial, looking at cyclin-dependent kinase inhibitors in early breast cancer, a trial called Natalie, using an alternative cyclin-dependent kinase inhibitor, ribociclib, and asking the similar question, folks with higher risk disease, would they do better with the addition of this agent? And another trial looking at more advanced disease, and Dr. Magoulian is the PI for that trial, and that trial asking the question, we follow folks with advanced disease, stage 4 disease, with serial scans. How are we doing? Is the patient responding to treatment? Do tumor markers guide us? Can they influence when we order CAT scans? Can we do less imaging, expose women to less radiation, and get similar outcomes? So a lot of interesting trials from different perspectives. And just to mention that more and more in the advanced cancer setting, we're looking to understand the molecular landscape. So we want to study the genetics of the tumor by a biopsy, and then sometimes by what we call a liquid biopsy, getting a blood sample and looking for circulating tumor DNA. And we're doing that more and more to try to tailor our treatment to the most effective therapies. And this is becoming commonplace for us. And this is a trial that one of our lead researchers, Dr. Pushtai, is going to be the PI of. And this is a trial in early stage disease and asking the question, well, if we follow women on endocrine therapy after they've had their surgery and they've had other treatment in the adjuvant setting, so after surgery, as when someone's say on either an aromatase inhibitor, if we check their blood intermittently, looking for circulating tumor DNA, if we see a certain signal as defined by the investigators, and we acted on that signal to change treatment, say from typical adjuvant endocrine therapy to adding, say, an agent like fulvestrant and a cyclin-dependent kinase inhibitor, for instance, do these folks do better? So again, trying to get at that question of if we come in early with different treatment, adding a second agent, will our folks do better in terms of disease recurrence? So I'm very eager to see this trial begin as well. And I want to briefly touch on, what might be new in genetics and how this could affect, some of our patients in the clinic and some folks who have certain hereditary risk. So we know that folks who have inherited a BRCA1 or BRCA2 mutation have some special issues with tumor DNA repair. And we call that homologous recombination deficiency. We know that some of these cancers are more challenging in terms of double-stranded DNA repair, because we know that cells are always having trouble, and if they can't repair themselves, they would have a signal to perish. And so we want to try to take advantage of maybe an inherent weakness within the BRCA1 cell. And there's a class of drugs called PARP inhibitors. I put two in here, olaparib and telazopirib, which are FDA approved for advanced cancer that have been looked at in trials in the stage 4 setting for women with BRCA1 and BRCA2 mutations. And they're effective and they're helpful. And they're part of our standard treatment regimen for folks who have BRCA1 and 2 mutations. And one of the questions that Nadine Tung asked at ASCO this year was, well, what about folks who might have other hereditary mutations beyond BRCA1 and BRCA2? Because we're finding there are other high penetrance genes that can increase the risk for breast cancer. would these people benefit from the addition of a PARP inhibitor? And what about folks who have acquired mutations in BRCA1 and BRCA2? So these are folks who don't have hereditary breast cancer, but their tumor cells have acquired mutations in those same genes, okay? And so the question, it's almost like an Achilles heel question. Well, if the cell has a problem with repair with one mechanism, because we know our cells are smart, so they've created multiple, evolution has created multiple ways for cells to repair themselves. If we take out this single strand DNA repair mechanism with PARP inhibitors, could that lead to cancer cells perishing? We call that concept synthetic lethality. And so this was a trial where folks with other mutations, and I just wanted to highlight what we thought were the seminal aspects of this trial. There's a gene called PALB2, partner and localizer of BRCA2, and it's a gene that also, when inherited, can increase the risk for breast cancer. And so in the hereditary setting, there was significant response with PARP inhibitors to the folks who had the PALB2 mutation. So to me, that's getting very close to saying, well, folks who have breast cancer in the context of this mutation, like BRCA1 and BRCA2, are candidates for a PARP inhibitor. What was also very interesting in the middle here is that folks who had acquired what we call a somatic BRCA1 and BRCA2 mutation, they too seem to have an excellent response rate to these agents in the advanced cancer setting. So this was interesting, and I think is going to be relevant for us. And just to mention, that's in contrast to folks with an ATM or CHEK2 mutation, two other genes that can be associated with hereditary breast cancer. Those folks didn't seem to benefit, okay? So I found that very interesting. And one of our investigators, Dr. LaRosso at Yale, has a trial. I just want to mention this trial because I think it's very relevant for our folks with germline mutations in BRCA1 and BRCA2. And you'll hear more about checkpoint inhibitors from Dr. Bulgaru, but this is a trial saying, well, if we have folks who have benefit from a PARP inhibitor, if we add a checkpoint inhibitor, might they do better? Because there's some very interesting science behind that, suggesting that those medicines could work very well together in our patients. So for me, it was a good year, a hopeful year, looking at ways to overcome endocrine resistance, some improvements as relates to how we understand hereditary cancer and the treatment thereof. And this is just a slide from the summer of some women that I know in Westerly who are doing yoga at sunrise on the beach. And for me, it sort of symbolized hope. And I do have great hope for this. I wanted to share that with you. Thank you.
That was fantastic. I love that last slide, and obviously all the data and the trials that are underway, especially here at Yale and Smilow. Next, we're going to move to Dr. Meena Moran and discuss the advances in radiation therapy and some of the really exciting techniques that are out there now. You're on mute. You're still on mute. But while those slides are coming, there was a question about 100%, it was from Pam regarding 100% breast tissue density and how confident you could be in imaging. I think that's a fantastic question. We're going to absolutely get that in our question and answer session. And also, what are the signs and symptoms of breast cancer? And I think really super relevant questions. So with no further ado, Dr. Moran, Professor and Director of Radiation Oncology at Yale.
Thank you. I apologize for that. I'm having some technical difficulties today. So I'm going to be talking to you about radiation, and just to give you an idea, one of the things I want to talk about is just the general principles of and practices for breast radiation, such as the role of radiation in breast conservation therapy, the role of radiation after mastectomy, and the use of radiation in the palliative setting. I want to talk about radiation, what it is, because a lot of patients that come for consultation don't really have an idea of what it is or what it does. And lastly, I want to talk about some of the technological advances that we now are using routinely in our practices to decrease normal tissue risk. So when a patient is newly diagnosed with early stage breast cancer, one of the major decisions that they face is the choice between a mastectomy or a lumpectomy, if they are a candidate for a lumpectomy. And this shows long-term survival following a lumpectomy with radiation versus a mastectomy. And as you can see here, that the outcomes in terms of long-term survival are equivalent. And this is nevertheless a persistent myth that patients feel that once their breast is fully removed, that their outcomes may be better. But unfortunately, that isn't. Fortunately or fortunately, it is not the case. And what we see is that more and more women over the last decade or so have been choosing mastectomy over breast conservation, but ultimately that the outcomes are the same. And so, what are the indications for when a patient may require radiation? The most common indication is in the use of breast conservation therapy, which is defined as limited surgery to remove the tumor with negative margins, and that's followed by whole breast radiation with an assessment of the lymph nodes. And breast conservation therapy, as I said, is a standard alternative to mastectomy for early stage breast cancer and provides equivalent long-term outcomes up to 25 years for eligible patients. So after lumpectomy, the alternatives to whole breast radiation can also be a partial breast radiation therapy plan, where the lumpectomy cavity is outlined and we're treating just that small portion of the breast. This approach is actually quite promising. It appears to have good cosmesis, but the studies are newer than the traditional whole breast radiation, and they have significantly shorter follow-up. And so currently it's only being offered for selected low-risk patients. And then lastly, there's one group of patients where we routinely offer them radiation omission or just having the lumpectomy with no additional adjuvant radiation. And this is for patients over the age of approximately 65 to 70 who have ER-positive tumors that measure less than 2 to 3 centimeters and who have negative nodes and who are willing to commit to tamoxifen for 5 years. And what we tell these patients is that their risk of the cancer coming back within the breast is higher, but if it does come back, they can ultimately have a mastectomy, and so therefore there is no survival difference. What are the indications for after a mastectomy to do radiation? Well, radiation is typically offered in the post-mastectomy setting for high-risk patients, and it's used to sterilize microscopic disease on the chest wall or in regional lymph nodes. Typically, the radiation is delivered to the entire chest wall and any lymph nodes at risk. The patients that we consider for post-mastectomy radiation are those who have positive nodes, those who have positive margins, if they have tumor that involves the skin, or if they have a tumor that measures 5 centimeters or greater. So whether it's post-lumpectomy or post-mastectomy radiation, it's important to recognize that radiation is very safe and effective and is much better tolerated than it was years ago due to the advances that we've made. And radiation generally reduces local and regional recurrences by approximately 60 to 70%, which is a relative risk reduction of about 2/3. In certain subsets of patients, radiation is also associated with an increase in survival, and it can be as high as 10%. And this is particularly true of the younger patients who have a very long life expectancy. The treatment is almost always given after chemotherapy, and the treatment duration of radiation is specific to the patient, and it can be as much as 6 weeks out from beginning to end. So the last major indication for radiation is for patients in the metastatic setting or in the recurrent disease setting, where a patient has disease that's causing symptoms. In these situations, the radiation is that's delivered is given in a palliative way, meaning that it's used to alleviate the symptoms that a patient might be experiencing. And it's highly effective. It can be up to 70 to 90% of patients do report that they have a very good pain control. But the fractionation differs significantly. It can be anywhere from 10 to 15 treatments or as little as 1 to 2 treatments, depending on the site and the performance status of the patient. And typically it's used for things like bone lesions, brain metastasis, soft tissue masses, or even chest wall recurrences. So just an important point, lastly, for all treatments of breast cancer, I think it's important to remember that every breast cancer is different. And so the biology is different in every case, as well as patient-related factors that a physician has to consider. In addition, we have to look at the efficacy of the treatment as well as the toxicity, and then look at the risk versus the benefits to make sure that it's worth the treatment for the patient. So in addition to the doctor's recommendation for whether or not to deliver radiation, another important component that sometimes gets neglected but should be discussed is the patient's personal preferences and what they want to do and how they want to proceed. So now, what is radiation? Radiation is a high energy X-ray beam, not very different than a chest X-ray or a CAT scan. They all use ionizing radiation, but the magnitude of the energy is significantly greater for therapeutic radiation. And ultimately what it does is it causes damage to any of the cells that are in the radiation's pathway. And so within our field of radiation oncology, our goal is to try to use the radiation to minimize the chance of the cancer coming back locally or regionally. And we do this by trying to individualize the beams to the patient's anatomy and target the areas at risk for recurrence and minimize the dose to the normal tissue wherever possible. So how does radiation work? Well, the individual X-ray beams target the DNA and normal cells as well through a direct and indirect mechanism that's a little bit too difficult to explain in this short session. But ultimately what happens is that the radiation causes damage to the DNA of any cell. And by doing this, it ultimately prevents the cells from replicating unless they can repair themselves. And so what are the exact types of damages? They're all different kinds, but the damages are typically such that the cancer cells are not able to recover from it, whereas normal cells, such as our skin, lung tissue, our breast tissue, is able to recover. And for this reason, it leads to cancer cell death when the cells try to reproduce or to replicate, whereas the normal tissue has the ability to repair and heal up and then continue with its normal life cycle. So when a patient comes in for radiation, sometimes they think that they're going to start radiation the day that they have the consultation. And this is just to show you that there's actually a process that we follow. The patient first needs to undergo a CT simulation, and it's a multi-step process where we put the patient on the table, we immobilize them to make sure that we can reproduce their positioning on a daily basis for the treatments. We add some markers to their skin, on their skin, and then we get the scan. This is what one of the immobilization looks like. It is a vac lock with a breastboard. Patients are required to put their arms up. And so for this reason, another important point is that when patients come to radiation, they should be able to raise their arms comfortably and keep them up for at least 20 to 30 minutes in order for the CAT scan and the entire simulation process to occur. And so this is what the radiation fields look like. And this is just a schematic, but basically what happens is the head of the machine moves to one side of the breast or the chest wall tissue, and it treats it and then moves to the other side and treats the other side of the breast. And by doing this, we're really skimming the chest wall and not penetrating from the front to the back. And in this way, we're really just treating the superficial tissue, which includes the breast tissue. Here are the wires that we put on to clinically delineate what we want to make sure that we're covering. And right underneath, you see the two CT scans. And in the pink, you have the breast volume. The yellow that you see there is the lumpectomy volume. And on the scan to the left side of the screen, you see the three little areas that are outlined are your lymph nodes in the axilla. And the red line that I drew is that tangential beam. So just to show you that we're able to cover a good portion of the breast and the level 1, level 2, and level 3 lymph nodes with just a tangential beam alone. So ultimately, this three-dimensional technology with the use of CAT scans and looking at it at every different level, it allows us to contour the beam to an individual patient's anatomy, and it allows us to deliver precise and focused radiation beams. So what does radiation target and what do we try to target? Most patients who undergo breast conservation have their whole breast treated at this time. We may or may not include nodes if the patient, if it's indicated for the patient. For example, if they have positive nodes, we often will include the regional nodes. After the mastectomy, we treat the chest wall, and more often than not, because these are higher risk patients, they will have their regional nodes treated. And this is what the fields look like on the skin. So this is just a schematic to show you what the delivery of the tangential beams are. First, there's the medial beam, or the medial part of the treatment. So you have the beam and sub-beams within it, which are tailored to the individual patient and deliver the radiation medially. Then the beam moves into the lateral position. So the head of the machine moves to the lateral side of the patient. And again, a similar beam delivers the tangential field and sub-beams as well. And ultimately, together, what that gives you is a dose distribution that looks like what that purple and the yellow there are covering. So you're covering a good part of, or almost all of that breast tissue with a very little amount of lung or heart in the field. And so the goal is, as we're doing this treatment planning, is to design the beams in such a way that we treat the breast and the chest wall with or without the lymph nodes, and we minimize the radiation to the normal tissue. And so we have a lot of tools that we are able to use, such as once we get the CAT scan, we can three-dimensionally recreate the skin surface as well as the three-dimensional internal surface, so that we are able to see exactly where these beams intersect, and also then be able to change the beam a little bit in order to make sure that we're covering what we need to cover. The things that we worry about, the most critical things that we worry about are the heart and the lung, obviously, and sometimes the liver. And so we have two important tools that we use regularly to minimize the dose to the heart and lung. The first one is the deep inspiration breath hold technique, and the other one is the prone breastboard technique. And I'm just gonna briefly talk about both of those. The deep inspiration breath hold technique allows a patient, when they take a deep breath, their chest wall moves away from the heart, and in doing so, and with the diaphragm going down, what you have is more room for that tangential beam to get in there and to be able to treat without exposing the heart, and also it reduces the amount of a lung volume. So this is just an example to show you in a patient. On the left is the free breathing scan, on the right is the breath hold. In red, you see the heart contour, how much the heart shape changes in this particular patient when she holds her breath. And that really allows us to get in to the chest wall, the breast tissue and nodes, and miss the heart. This is just a cross section of that, showing you again the decreased heart dose. On the left, you have the free breathing. On the right, you have the breath holds, and how significant that change in anatomy is using this breath hold technique. So then the question is, well, okay, fine, you do that on the CAT scan at the time of CT simulation, but what do you do day to day for the 6 weeks of treatment that you're bringing the patient in every day? Well, we have very sophisticated lasers within the treatment room that project onto the patient's skin and determine the exact position that the body contour should be in when the patient takes that deep breath. And these reference points are locked into our record and verify treatment system. And so the machine only turns on and delivers the radiation when the patient is in that exact precise breath hold. And this is within 3 millimeters. So anything more than 3 millimeters, the machine will not turn on. And the patient holds their breath as long as they can. The machine delivers. It does what it's supposed to do. As soon as the patient releases their breath, the machine turns off, and then the patient catches up on their breath, and you repeat the cycle until the entire treatment is delivered. So this is just a data showing you just one study looking at DIBH in patients who do free breathing. These are just some cardiac parameters. You see that only about 50 to 60% with free breathing can avoid the cardiac structures to what is considered acceptable. With deep inspiration breath hold technique, that increases to about 97%. So it's remarkable that it works very well in the vast majority of patients. But what about that last 3% of patients where the DIBH doesn't work? Well, we have another technique. It's not as precise, but it does work very well. It's the prone board. And what we do is instead of having a patient on the left there with their laying on their back, you can see that their heart is clearly in the field. We put them in the prone position, and we use gravity to have that breast fall forward, and it allows us to treat the vast majority of the breast tissue and the chest wall without having to treat the heart. And so this is our alternative method for decreasing heart dose, and it works quite well as well. This is what the breast board looks like. Again, the ipsilateral breast, or the side that we're treating, hangs down. The other side is pushed up and out of the way. We do similarly outline the volume of the breast tissue and the lumpectomy cavity. And an important point is that if a patient has a tumor that was originally very close to the chest wall, that would be a patient, for example, that we would not want to do breath holds. Not do prone breast board on, because you are skimping a little bit on the very, very posterior aspect of the chest wall there. But in the vast majority of patients that we do it in, as long as they're appropriately selected, it's a very effective technique as well. So in summary, radiation is an essential component to the multidisciplinary approach of breast cancer. And as I mentioned to you, for early stage breast cancer, breast conservation therapy is equal to mastectomy, meaning that there's no difference in survival rates. And for this reason, I like to stress that mastectomy shouldn't be chosen by patients under the false pretense that they're going to have better outcomes by removing the whole breast, because this isn't the case. Also, don't choose mastectomy just to avoid radiation, because you don't want to go through 5 weeks or 6 weeks of radiation, because even after mastectomy, there are going to be patients who are going to require post-mastectomy radiation. And lastly, that with the current technology and the advances that we have, radiation has really become quite safe and effective. It does decrease local and regional recurrences by about 2/3. There's also a survival benefit in some patients, and it's much better tolerated than it was years ago. So I often will have patients who come to me and say, oh, my mother had radiation 20 years ago and it was awful. It's not the same as it was years ago. Our technology has advanced so much that the vast majority of patients tolerate it very well. And if you need it, it is not necessarily something to fear. So thank you for your time, and thank you for calling in this late in the evening.
Thank you, Dr. Moran. That was fantastic. Loved it. I actually learned a lot and was almost holding my breath while you were talking about it. And now, last but certainly not least, Dr. Anca Bulgaru, talking about, again, more, the amazing changes that are ongoing in medical oncology. We've gotten a whole slew of questions. So once you're done, I'll be asking our panelists for their thoughts and opinions.
Good evening. It's a privilege for me to be part of the Smilow shares and moreover to be part of the same treatment team at Smilow Waterford with Dr. Legare and Dr. Moran. I would like to share the screen. So Dr. Moran, would you mind to unshare?
Yeah, I have unshared. Stop sharing. Yeah, there you go.
Okay. Okay, sorry. I am. So in my talk, I'm going to focus on some novel treatment options in HER2 positive and triple negative advanced breast cancer. We do know that not every case of breast cancer is the same. As Dr. Legare mentioned, approximately 70% of the breast cancers are hormonally driven. However, there are other cancers that may have a different driving pathway that is called HER2, and they represent approximately 20 to 25% of all breast cancers, while 10 to 15% of breast cancers, are considered triple negative. They do not have expression for estrogen, progesterone, or HER2. And it is important to know which subtype of breast cancer you're dealing with, because the survival and the prognosis is different. The best prognosis is for the hormonally driven cancers, but the HER2 positive, either with ER positivity or concurrent ER negativity, as well as the triple negative breast cancer, may not have the same excellent prognosis. In the last several years, we've had tremendous advancements in the treatment of triple negative breast cancer and HER2 positive breast cancer, and I'm going to mention two such advances for each subtype. What is HER2 positivity? We do know that the normal breast cells and most of the breast cancer cells do have a certain number of HER2 receptors. HER stands for human epithelial receptor, and in that class we have 4 different categories. For breast cancer, the HER2 are the most important. So these HER2 receptors are transmembrane proteins, and when a ligand, the growth factor, attaches to the receptor, it induces the dimerization, the pairing of that receptor with another one, and that in turn will activate the internal part of the receptor that is called the tyrosine kinase, and it will trigger a sequence of events that would lead to activations of pathways and genes inside the nucleus, and ultimately lead to growth, to proliferation. In approximately 25% of the breast cancer, we have an overexpression of HER2 receptors and or overexpression of the genes, the HER2 genes in the nuclei, and that leads to an exuberant activation, if you may say so, of the proliferative pathways inside the cancer cells that could lead to a more aggressive growth and cancer spread. And the importance of this pathway was recognized in the 1980s. And while this pathway confers the cancer more aggressiveness, it also gives us the opportunity to interact with it and to treat. And a big component of that improvement in the breast cancer mortality that Dr. Legare mentioned is basically due to the advancement in the HER2 positive breast cancer treatment. So in the late 1990s, the first drug that was approved by FDA was Trastuzumab. This is a monoclonal antibody that attaches to the HER2 receptor and basically blocks the proliferative pathway. There are several mechanisms. It could also induce the degradation of the receptor, prevents shedding, but nevertheless, the Trastuzumab made a tremendous difference in the overall survival of patients with metastatic disease. And later it was brought to the earlier stages of the breast cancer and significantly improved the chance for cure and decreased risk of recurrence for early stages breast cancer. In 2012, we had the advent of Pertuzumab that blocks the pairing of the HER2 receptor with the HER3. This is the strongest way of stimulating the HER2 pathway. And together with Trastuzumab, again, brought additional benefit for metastatic breast cancer cases, patients, and now it's also approved for treatment of patients with early stages breast cancer before their surgeries. A newer concept is the antibody drug conjugates, and I'm going to talk in more detail in the next few minutes. So these monoclonal antibodies are large molecules that act outside the cell membrane. But we also have a class of drugs that are called targeted tyrosine kinase inhibitors that are smaller molecules taken by mouth that could basically block the tyrosine kinase, the internal part of the HER2 receptor. And by doing that, it basically stop this activation of the metabolic pathways. And they do have slight differences. There are some slight differences between the three compounds, and the newest one is tucatinib. And again, I'm going to talk a little bit later about it. So the antibody drug conjugates represent a significant advancement in the treatment of breast cancer. And basically, the antibody molecule that is Trastuzumab is loaded with several small molecules of a potent cytostatic or potent chemotherapy that is delivered directly to the cancer cell overexpressing HER2 receptors. So it's a targeted chemotherapy delivery system. So after it attaches to the receptors, it gets internalized in what we call an endosome. And after activation of certain enzymes in what it becomes now the lysosome, the chemotherapy medication is released inside the cells and kills the cells. So different antibodies have different abilities to release less or more of these chemotherapy molecules. And we do know that some of the chemotherapy can diffuse into the neighborhood. It can diffuse outside the cell and actually kill some other cells in the neighborhood that may not be so strongly HER2 positive. So this is what we call a bystander killing effect. So the first antibody drug conjugate that was approved by FDA in 2012 was Trastuzumab Etamsin, or TDM1. And basically, it's a molecule of Trastuzumab with 3.5 molecules of maytansine. That is a very strong cytostatic that would be too toxic to be to be used as a treatment on its own. So this medication made a significant improvement in the outcome of metastatic breast cancer when used in second line after patients progressed on usually Trastuzumab and Pertuzumab plus a taxane backbone chemotherapy. But as of 2019, it got FDA approval also for treatment in adjuvant setting if patients are treated with trastuzumab and pertuzumab and chemotherapy, and they have residual disease at the time of the surgery. Those die-hard cells could be better killed by this targeted delivery of the chemotherapy. In December 2019, FDA gave accelerated approval for a new antibody drug conjugate called trastuzumab deruxtecan. The commercial name is Her2, and while we are not supposed to use commercial names, it's much easier to pronounce. So compared to TDM1, this antibody delivers a much higher payload of chemotherapy. It has 8 such molecules attached to it. And what happens, the linker that attaches the chemotherapy, that is a topoisomerase 1 inhibitor, to the trastuzumab, it's cleavable, meaning like it gets cleaved easier inside the cancer cells, and that accounts for a much higher bystander effect. In addition, this molecule has a much higher affinity for the Her2 receptors compared to the Herceptin and also to the TDM1. So the approval is based on this Destiny Breast01 trial, which basically was a single-arm phase 2 trial that enrolled 112 patients who were heavily pretreated. So that means they had received a number of chemotherapies before. The median number was 6, but there were patients who received as few as 2 and some other patients who received as many as 29. And in such a heavily pretreated population, usually the response rate is very low. But in this is the waterfall plot analysis, and basically each line represents an individual patient, and the length of this bar or line basically reflects the depth of the response. And a picture is worth 1,000 words. You can see that the vast majority of patients had a shrinkage in their tumor. So we call it stable disease if it's shrinkage less than 30%, and the significant or a partial response if it's more than 30%, and progression when it's more than 15%. So 60.9% of the patients treated with trastuzumab deruxtecan achieved response rate for and 76% of the patients had control of their disease at 6 months. This response lasted for at least 14 months. And not only that it worked, but it worked fast with a median time to response of 1.6 months, which means like a little bit more than 6 weeks. The overall survival in this study has not been reached. The medication is well tolerated, mainly with neutropenia and some fatigue, but there is a particular side effect that requires attention, and it's called interstitial lung disease, that usually presents with shortness of breath and cough, and on the imaging studies would show some ground glass opacities. So the doctors do know to monitor for such side effect very carefully. Of note, patients with HER2 positive disease have a higher propensity for developing brain metastases, and such patients are usually excluded from the clinical trials. In this Destiny 01 trial, 24 patients with stable brain metastases were included, and that progression-free survival was 18 months, and that is absolutely remarkable. But I am glad to say that there is another drug that also got recently approved, and that could give us even a better hope for such patients with brain metastases. And this is the selective tyrosine kinase inhibitor called tucatinib. And if you, as I said before, it works at the intracellular portion of the HER2 pathway. So the HER2 Climb patient, HER2 Climb trial randomized 612 patients to chemotherapy with trastuzumab and capecitabine with or without tucatinib. So some patients received tucatinib, some patients received the placebo. And 48% of the patients, so almost half of them, had brain metastases. Some were stable, and some were newly diagnosed but not requiring immediate treatment, and some had progression after prior treatment. So in the overall population, there was a significant improvement in the disease control, what we call progression-free survival, with 46% reduction in the risk of progression. And that translated into an improvement in the overall survival with 34% reduction in the risk of death. When we look at the patients with brain metastases, the overall response rate was 47% for patients who had the tucatinib treatment versus placebo. And that translated into an unprecedented improvement in the progression-free survival at 1 year. Like 35% of the patients were alive and with control of their disease, and also in the overall survival. So these two medications, trastuzumab deruxtecan and tucatinib, represent major improvements in the treatment of the advanced HER2-positive breast cancer. They are now being studied in more and earlier lines of therapy, in post-neoadjuvant therapy for the trastuzumab deruxtecan to replace the T-DM1 or second line, and also looking at their effect in the HER2-low positive disease. So shifting gears to triple-negative breast cancer, we define it by what doesn't have, by the lack of estrogen, progesterone receptors, and the Her2 receptors. And it represents 10 to 15% of all breast cancer cases, more common in African American and patients and those of Hispanic heritage, younger women, those who are BRCA1 mutation carriers. We do know that 85% of BRCA1 associated breast cancers are triple negative, and conversely, 10 to 15% of the triple negative breast cancer patients have BRCA1 mutation, and they do have a more aggressive behavior. But even triple negative breast cancer is not the same disease. There are different subtypes. The researchers from Vanderbilt University did remarkable research and identified several subtypes. There were 7 initially, and they were narrowed down to 4. And I'm not going to go into details about the specifics of each subtype, but just to mention that there are different genetics and molecular differences, and there is extensive research trying to target them and find particular solutions and treatments for each breast cancer subtype. So we do have breakthrough development in the treatment of triple negative breast cancer, and this is a drug called sacituzumab govitecan that was approved in April of 2020 for treatment of triple negative breast cancer. So this is a targeted antibody drug conjugate similar to trastuzumab deruxtecan, but in this case it targets a TROP2 antigen that was found to be expressed on many epithelial cancers, such as bladder cancer, breast cancer, initially thought to be specific for triple negative breast cancer, but recent research showed that actually it's equally expressed on the ER positive breast cancers as well. So the antibody targets this antigen, and the antibody has a high payload of chemotherapy called SN38. This is a metabolic product of a chemotherapy that we know, irinotecan, that is basically used to treat GI malignancies mainly, and it's not necessarily part of the armamentarium that we have for the triple-negative breast cancer. So it delivers a novel chemotherapy to the triple-negative breast cancer cells. And what is also particular about this compound is that the linker is very pH sensitive, and that has a very it is released very easily into the cancer cells, and also has an important bystander effect. So this medication was approved based on the results of a phase 2 trial where women were treated in third line or above, and there was a response rate of 35% with progression-free survival of 5.6 months and overall survival of 13 months. So at European Society of Medical Oncology in September 2020, or ESMO, the results of the ASCENT trial were presented. And basically this trial compared sacituzumab govitecan versus single agent chemotherapy in metastatic triple-negative breast cancer in women who already had at least 2 prior chemotherapy regimens. And this novel medication was compared to whatever the physician thought would be the best possible choice for that particular patient. And there was a significant improvement in the progression-free survival from 1.7 months to 5.6 months. And there was also an improvement in the overall survival. So this is the first study that showed an improved survival over standard of care in triple-negative breast cancer. And the results, again, are unprecedented. And this drug is going to move to earlier stages of treatment. It is well tolerated, with main side effects being anemia, neutropenia, and diarrhea that is usually very well controlled with Imodium. So using the same concept, but targeting different antigen called LIV1A, there is a drug called Radiotherapy that is in clinical trial, and we are happy to say that it's open at Yale through phase 1 program. And we do know that some of the triple-negative breast cancer do have a low expression of the Her2 receptors, and trastuzumab deruxtecan is being studied in this setting as well. And the sacituzumab govitecan is also studied in ER-positive metastatic breast cancer. And again, I'm happy to say that we have a clinical trial called TROPICS-2 open at Yale. So over the last decade, the advent of immunotherapy has changed the natural history of many cancers. And obviously, there was a question, would that make a difference in metastatic triple-negative breast cancer? We do know that the body has an innate immune system that is supposed to protect us against the invaders, against the breast cancer cells. And when the abnormal antigens are recognized, the T cells would come and destroy the cells. However, the cancers do learn to fight back. So we do have this checkpoint mechanism that basically also has a good role to prevent the T cells of attacking the normal cells. But the tumor cells take advantage of that by overexpressing what we call the program death ligand and binding the PD-L1 receptor and binding the PD-1 receptor on the tumor cells and turning off the surveillance of the immune system. And by doing that, they manage to grow undetected. So fortunately, we do have a new class of drugs that are called immune checkpoint inhibitors that could block either the PD-L1 receptor or the PD-1 receptors. And by doing that, the T cells are now allowed to detect the cancer cells and destroy them. So several such drugs were investigated in particularly in triple-negative breast cancer, and as single therapy in first-line setting, the response rate was not that impressive, maybe only in the low 20%. But what is intriguing is that there are patients, there are responders who have a very durable response and potentially be cured. So Impassion 130 was the first trial that basically combined PD-L1 inhibitor atezolizumab with the chemotherapy backbone of nab-paclitaxel for women with triple-negative breast cancer and or locally advanced unresectable breast cancer. And they were treated and the statistics have showed a significant improvement in the duration of the disease control of more than 2 months. But actually the benefit was seen only in the patients who had the PD-L1 expression positivity using the specific assay called Ventana SP142. In this particular clinical trial, 40% of the patients had the PD-L1 positivity, but we do know that in real life, only 20 to 30% of such patients are positive. So the disease control translated into an improvement in the overall survival of 10 months, from 15 to 25 months for this PD-L1 positive population. And FDA approved the use of atezolizumab and nab-paclitaxel irrespective of the line of therapy, but we do not have we really don't have data to know what would be the benefit beyond the first line treatment. So another study that was presented at ASCO 2020 used this time a PD-1 inhibitor called the pembrolizumab and combined it with different types of chemotherapy. There were 3 different regimens: nab-paclitaxel, paclitaxel, and gem-carbo. And the patients were treated until progression, toxicity, or completion of 35 cycles of treatment. And we did see an improvement in the progression-free survival that again was limited to those patients who overexpressed the PD-L1. They used a different way of describing their positivity, a CPS score, which looks at the total % of cells that are positive, including the tumor cells, lymphocytes, and macrophages in the tumor. So this regimen is not FDA approved yet, but it is up for approval. And I think the message to take home from this study is that you can use different chemotherapy backbones, different chemotherapy regimens in combination with immunotherapy, and you can tailor the chemotherapy used based on the patient's toxicities and prior treatments. So I'd like to say that there's the question, why do certain patients stop responding to the immunotherapy? And there are mechanisms of resistance with activation of the MEK or AKT pathways. And fortunately, we do have inhibitors, tyrosine kinases, that could turn those pathways off. And there are some early studies that basically combine the MEK inhibitor called cobimetinib, that is FDA approved for treatment of melanoma, with Taxol and atezolizumab, so basically the same regimen from the Impassion 130 trial. And early results show an excellent control in the tumor burden and very promising response rates. So the chemoimmunotherapy was brought to earlier phases of treatment in neoadjuvant setting for women who have triple negative breast cancer and are treated with curative intent before the surgery. And there was a significant improvement in the rate of pathological complete response and event-free survival without significant increase in the adverse events. This regimen is not FDA approved yet, waiting additional data in the overall survival. So I try to make a point that important breakthrough developments, that we do have important breakthrough developments in the treatment of HER2 positive and triple negative breast cancer. The treatment has to be personalized based on the cancer subtypes and different molecular characteristics of the tumor, but also looking at the patient's comorbidities, prior treatments, and patient's preference. And participation in clinical trials is very important to continue to improve the outcome of different types of breast cancer. I am very happy to say that we have an expanding large list of clinical trials for all subtypes and all stages of breast cancer at Yale. And we are all a team fighting for hope and also fighting for curing breast cancer. And these are some contact information if you choose to call us after this meeting is over. Thank you.
Thank you so much, Dr. Bulgaru. That was quite a tour de force in the latest in medical oncology and drug therapy. We actually don't have a ton of time, but there were so many questions. I just love this panel, and more importantly, the attendees who really took so much time out of their evening to stay with us and listen to what Smilow and our cancer center is doing. So this is almost like speed dating. I'm going to fire off some questions to our panelists, and hopefully just keep those answers as quick as possible, because really all of our attendees really deserve answers to their questions, which I tried to do in the background. A couple for Dr. Moran. One is a question on angiosarcoma after treatment for radiation therapy 10 years after mastectomy. This comes from Ann Peterson and from her mom, who required a pretty extensive resection. What percentage of patients develop osteosarcomas, and is there a gene that can differentiate with that? And kind of moving along those lines is, does radiation damage the skin and tissue, thus making reconstruction difficult after mastectomy?
Okay, so to answer the first question, yes, second malignancy in the radiation field can occur. It is pretty rare. We quote the number of 0.01% at 10 years, and I think, you know, that's probably accurate at best. I've seen maybe 2 in my 20-year career of a sarcoma that was radiation induced. So it's unfortunate there isn't any way for us to be able to identify those patients other than maybe possibly the ATM mutation, which isn't necessarily linked to sarcomas per se, but they do have significantly more toxicity from the radiation, and it could be that they have a higher incidence of second malignancies related to the radiation. The repair mechanisms are not as established as someone who doesn't carry that mutation. The second question, as far as reconstruction, that is a very very excellent question, and we deal with this all the time. Yes, radiation does cause damage, and for this reason, when you undergo a mastectomy and then get radiation and then have reconstruction in the delayed setting, what needs to happen is a couple of things. One is that you want to wait at least 6 months or so to allow the skin to completely heal. 2 is that you want to have an experienced plastic surgeon who knows and has experience with the radiation and how that tissue looks like intraoperatively. And third is that unless you've had an expander placed, you really can't do an implant-based reconstruction. And so for that reason, most of those patients who have delayed reconstruction and haven't had an expander placed will have to have a autologous flap. And what that means is just putting in tissue from somewhere else, whether it be their abdomen or their back or their butt. So.
Thank you. Kind of going back to an earlier and just more generalized question on, you know, how confident can we be when you have a really dense breast tissue on mammogram and ultrasound in terms of detection of cancer, and how can women self-check outside of their annual mammogram, especially when some of the recommendations for self-breast exam are no longer recommended? This is just open to any and all of our panelists.
Bob?
Oh, sure. So in terms of the dense breast tissue, you know, we know that, you know, that's common. Maybe half of women have breast density. It's categorized and defined. We know that can decrease sensitivity for mammogram. We know younger women are more likely to have, you know, denser breast tissue, but older women can have denser breast tissue as well. So we know there's some limit to sensitivity. We still know that mammography is the one tool that's been shown to define and reduce mortality from breast cancer. So we still do use mammogram. I would say that these days, and we're fortunate in the United States, we're pretty much always using digital mammogram, and most of us are also using tomosynthesis, which gives us a little bit more sensitivity still in terms of getting more of a 3D picture of the breast. And then just to comment on ultrasound, I usually tell my patients that ultrasound might pick up maybe 3 or 4, maybe 4% per thousand more breast cancer. So it's something that, you know, some women choose. As all of us know, that's in part political, but when you look at the medical aspect of it, it's an option for women with dense breast tissue. And we know that MRI is out there and it's used selectively in high-risk populations like germline mutations or other populations. And we know that that, you know, could be considered a gold standard in terms of sensitivity, but we use it less for multiple reasons. Was there a second part to that question? I'm sorry.
In terms of self-breast exams, thoughts on that?
Yeah, you know, the data hasn't shown us that breast self-exam, you know, improves, you know, survival or as relates to breast cancer. And certainly some women still choose to do that, and it's their right to do that. And I would say that if one is doing that, maybe just being trained to do it most effectively, but you know, we don't have necessarily other tools, but that's not something that we generally recommend, though certainly someone certainly choose to do that.
Thank you.
I could add to that we cannot really rely on the breast exam to detect the breast cancer, and that's the value of the screening mammogram, to detect them way before the breast cancers become palpable. American Cancer Society discourages self-breast exam as a routine detection method, but the NCCN guidelines do include a recommendation for what we call breast awareness, because it is very important for women to know how their breasts feel like. It also, for premenopausal women, the best time to check would be 7 to 10 days after the onset of the menstrual periods, when there are less hormonal changes in the breast. And we do know that 10 to 15% of the breast cancers are diagnosed because women do find a lump in the breast. So I think that while never say I'm just going to rely on the breast exam, go for the screening mammogram, I do encourage my patients to have a breast awareness and be aware of how their breast tissue feels like.
Yeah, I agree with that as well. And I also tell patients, for anyone that's had radiation, as they're finishing their radiation, I tell them that during the first 6 months post-radiation that they should actually do a breast exam, not to be alarmed, but that all the changes that they're feeling is the scar tissue that's developing, because with radiation, you develop scar tissue just like you do with surgery. And it's just an opportunity for them to learn what their new breast feels like, so that down the road, they're not alarmed if they suddenly check their breast at 1 year and suddenly feel lumps and bumps lumps, because the vast majority of them are just scar tissue and normal.
And this is for two things from Caitlin. One is she said, please do self-checks, and that's how she found her cancer. And again, absolutely, if a woman feels comfortable with their own breast exams and seeing any changes or noticing them, I 100% supportive of doing self-breast exams. She also had a really thoughtful question about stage 2A triple positive breast cancer with no lymph nodes. What are the thoughts on Neuralinks, and also thoughts on oophorectomy on a 36-year-old female on tamoxifen for the above mentioned diagnosis?
Want me to comment on that? Neuralinks, I believe you're referring to neratinib, which is an oral sort of pan HER2 tyrosine kinase inhibitor. And that was studied, and it seemed to be more effective perhaps in the ER positive group. I believe that was the Extenet trial. It's oral. I think it was taken for a year. Has some pretty significant side effects in terms of especially diarrhea, but there's ways to sort of try to preempt that and prophylax against it. I believe that trial also did include women who had neoadjuvant therapy, and there was a similar trend in terms of benefit. The interesting thing, at least to my as I recall, is that in that trial, women hadn't seen Pertuzumab, which is now sort of a standard complement, as Dr. Bulgaru was showing us earlier, with Herceptin, which is also called Trastuzumab, in the sort of neoadjuvant and then sometimes following into the adjuvant setting. So there is some data there, but there's not really data looking at that agent in the setting of prior exposure to Pertuzumab, at least to my knowledge, in addition to Trastuzumab. And then the second part, Dr. Bulgaru, did you want to comment on the second part?
Sure. So it is well established based on the large soft text trial that young women do benefit from ovarian suppression. That is done with drugs like Zoladex or Goserelin, and in addition to oral anti-hormonal treatment. Now the removal of, that basically puts the patients into a chemical menopause. There is the option of a surgical menopause, particularly if there is a genetic predisposition for ovarian cancer. But that is an irreversible option, So I think that it has to be discussed with your treating physician, the pros and cons of prophylactic oophorectomy. If there is a cancer predisposition genes that would increase the risk for ovarian cancer, and someone is really sure that is done conceiving, then prophylactic oophorectomy is an option. But otherwise, ovarian suppression with this every 3 months injections is the standard of care, in addition to oral anti-estrogen therapy. And then you have the tamoxifen, or even better, an aromatase inhibitor.
Thank you so much. First of all, to our panelists, a round of applause, although we won't be able to hear it, for Dr. Bulgaru, Legare, and Moran, for really 3 state-of-the-art fantastic talks, and here at Yale and the Smilow Cancer Center, at Waterford, L&M, Westerly. It was a great evening, and really, more importantly, to our attendees, our cancer survivors, those that are going through this right now. Your questions were super thoughtful. I tried to answer some of them while our panelists were giving their talks. This has been recorded, and you can go back to it. And of course, we're always here for you and happy to answer any questions. Thank you so much for a wonderful evening, and stay healthy. Take care, guys. Thank you.
Thank you.
Thank you.